My name is Abby White. I'm a graduate student at the University of West Georgia and graduating soon in May. And I'll be talking to you guys about supporting dysphagia. Dysphagia is a swallowing disorder characterized by underlying impairment that impacts the normal swallow anatomy or physiology. It's got several stages. In our oral stage, we've got our lips and our cheeks, the tongue and jaw, all kinds of moving parts. The oropharyngeal stage of swallowing is kind of right in between the oral and the pharyngeal stage, and it's a mixture of deficits in both. Pharyngeal dysphagia is in the throat and all of its parts. Our biggest concern with that is protecting the airway. And then there's also esophageal and gastroesophageal dysphagia. We don't touch those. For those, we refer to a gastroenterologist. So pretty much the way I explain it to my patients, if it's from here down, we don't do it. But from here up, speech is pretty much concerned with everything except the eyes.
Yeah.
So, as I said, underlying impairments impacting the normal swallow. With dysphagia, we've got aspiration and penetration, which are words that we kind of throw around. There's no way for us to tell for sure if a person is aspirating by just looking at them. You have to be able to see these structures. So aspiration is when it gets in here, in the very top of the airway, into the trachea. Penetration is when it goes through the vocal folds and actually enters the trachea. So that's where we run into a lot of coughing, of course, with aspiration or penetration. Coughing can be super scary. I'm sure y'all have fed somebody or gave somebody something to drink and they start hacking up a lung. You're like, are they gonna die on me? I hope not. But coughing is a really good sign. That means their body's trying to protect itself. So if they're coughing, be like, good, keep coughing it up. Get all of that out of there. Exactly. Now we're gonna get into the signs and symptoms of dysphagia. I wanna play a little game called Name That Stage. We've got oral dysphagia, pharyngeal dysphagia, and esophageal dysphagia. Those are the ones we'll be using for this Name That Stage. So if a patient is coughing during or right after eating or drinking, what stage would that be?
What was the first one you said? I'm sorry.
Oral, pharyngeal, and esophageal.
Would it be?
It's not oral.
It's the second one.
Pharyngeal.
Yeah,
It's
pharyngeal.
pharyngeal. So our pharynx is the throat. And
Okay.
we're coughing because we've got some going into our airway. A wet or gurgly voice after eating or drinking. What stage would that be?
Oral?
Good guesses, but no. Again, pharyngeal. Here we go. We're learning things today, ladies.
We are.
So it's wet or gurgly because the liquid or food, usually it's liquid, is sitting on the vocal folds.
Okay.
So that's where you get that gurgle from, and it's just residue that's left over usually.
Okay. And that is
Pharyngeal.
pharyngeal.
Pharyngeal. Right here.
Pharyngeal.
Prolonged chewing.
That's oral.
That's oral. Labial escape or spillage. That's when it's coming out of the corners of our mouth. What
Okay.
stage?
Oral.
Oral.
Got it. Complaint of food getting stuck in the throat.
So that was
The
the.
one you just said.
Yeah.
The P one. Pharyngeal.
Pharyngeal.
Yep.
Pharyngeal.
Why can I not remember?
Right here in the throat, pharynx.
Okay.
It's the same.
Yeah.
Yep. What if it's getting stuck in the chest?
That's the last one you said. What's
Ooh.
it? It's esophagus.
What is it?
Esophageal.
Esophageal.
That means their esophagus is not letting it go all the way down, or sometimes it'll come back up the esophagus, which is
Okay.
where we run into GERD with
Okay.
reflux. Recurrent pneumonia, what stage would that go with? Is that tricky?
Recurrent.
So we've got pneumonia in our lungs.
Is it
Keeps
the same
happening.
one?
It's not esophageal. The esophagus goes down to the stomach.
Okay.
So is it the
Yep. Pharyngeal.
the throat? What is that? Pharyngeal throat. If I gotta
Yes.
remember that.
The pharynx.
You know what's so funny about this? The words that you're telling me, I learned this a while back. So when you were just talking, I said, okay, I remember. Okay.
It's just so long ago. You know, it helps to stay fresh.
Yes.
Gotta have a little challenge sometimes. So that's the pharyngeal stage where we're going into our airway and it's impacting our lungs. What about chest congestion after eating? Some of them will, get one of those rough coughs where it sounds like they've got a bunch of stuff.
That's
Like
the
a rattle or
esophagus.
something.
Mm-hmm.
Somewhere in it.
That's the esophagus. No.
Nope.
It's not esophageal. No.
Esophageal goes to the stomach.
That's right.
Our chest
pharynx.
congestion would
Is
be
that
in
the-
our lungs.
The
Yep,
throat.
the throat. The pharynx.
Okay, and the other one is the stomach.
Mm-hmm.
Okay.
Yeah.
Weight loss or dehydration?
From here.
Oh, that's the
So
stomach.
that's the stomach.
Yeah, that's
Yep.
the
So that's the esophagus.
So it can be from
Pronounce it.
esophageal.
Esophageal.
Mm-hmm. The esophagus. So that means we're not getting enough into our stomach.
Okay.
That can be because the esophagus isn't working right. It can be that we're not even getting it to the esophagus. Or it can even be oral, that it takes so much effort to chew something up and swallow it that we don't want to eat anything else.
Okay, gotcha.
So, kind of all of them with that. Pocketing food.
That's oral.
Mm-hmm. We keep a little bit on this side. What about reflux?
Throat again. Right.
No.
No, so that would be esophageal.
That's esophageal.
Okay.
So the esophagus with that, sometimes it makes a little pocket and holds on to some food or liquid, or sometimes it just constricts and doesn't let it all go down, and it'll come back up.
Okay.
So anything that's not making it into the stomach may come back up.
Okay.
And that is just as much of an aspiration risk as food that we're eating. You can aspirate on reflux just as easily as you can food. Silent aspiration.
I'm curious about that.
Do you know what that is?
That's the throat one, right?
That's the throat in the pharynx. What is silent aspiration?
That's what I was just gonna ask you. I don't know. I'm
Okay.
just
Okay.
Never seen that.
Well, good.
I'm
We're
very
learning
curious.
stuff. Okay, silent aspiration is aspiration
Mhm.
that's silent. So either the patient doesn't feel it going into their airway or something like that, but they're not coughing when they aspirate. So instead of them getting that back up and protecting their airway, it's going straight down into the lungs. And that can be really dangerous. That's why a lot of times we won't just give somebody thin liquids because they may be aspirating and we have no idea.
Right.
The only way to see that, again, is with the imaging studies. So even just looking at them, you can't tell
And so how
But-
long can somebody go
That's what I
with
wanna
doing
know.
that without,
until it kills them.
oh wow.
Because that one, the reason why that's standing out to me, because I honestly believe that's how my aunt passed away. That's why I was
It
just
could be.
so, that one, and the way you explained that,
Yeah.
she wasn't having any of these other signs.
Yes, so with silent aspiration, we pretty much have no signs or symptoms. And a lot of times, if y'all could look at my notes, it says patient tolerated trials with no overt signs or symptoms of aspiration. And that's because I don't know if they're aspirating or not, but I can't tell that they are.
Okay.
So that's what's going on there. A lot of patients may also experience disinterest or less enjoyment in eating. They may be embarrassed about eating, especially if we're spilling stuff out the front of our mouth or we have to clean out our pocketing every few bites. That can be very embarrassing.
Yeah.
And because of that, a lot of patients may want to isolate. I've had a patient ask me if I could kick their family out so they could eat lunch. So it can be very isolating, but something I do to encourage these patients is like, hey, you're not the only person that has to deal with this.
Right.
And especially the ones coming into dining, all of these people need help with their swallow or feeding themselves in some way, shape, or form. So, but I still have some that I'm not doing that. That's embarrassing.
Right.
Especially about cleaning the pocketing
Yeah.
out.
Gotcha.
what are some risks associated with dysphagia? We went over a couple of them, but we're going to get a little more in depth here.
Some risk.
Maybe if they're on thickened liquids, what's something we have to look out for?
Make sure that it's going all the way down, like they're swallowing
Yeah, make sure
it.
they're swallowing it.
Make sure they're swallowing it. And a lot of patients that are on thickened liquids, don't like the thickened liquids,
Mhm.
and they won't drink the thickened liquids. So we've got to make sure we're staying hydrated.
Mhm.
Dehydration and malnutrition are huge in patients with dysphagia. So we want to make sure we're encouraging them to eat, encouraging them to drink as much as we possibly can. And some of them still may not.
Yeah.
I got a patient like that right now.
Yeah.
Yeah.
All you can do is try your best and,
Yeah.
and let them do their thing. It can also compromise their general health. So along with malnutrition, which can compromise your general health, just being weak and not getting enough sustenance can compromise your general health. They also may acquire chronic lung disease from their lungs constantly going through the trauma of food or liquid coming down there. Aspiration pneumonia is huge. That's one of our biggest concerns with dysphagia. And I'll get into a little more of what that is and how we can protect it. And then dysphagia can also lead to death, which, if you're choking on stuff, that's a risk, but sometimes we forget about it. When I first came, I really did not want to do anything with dysphagia because I was afraid of giving somebody the wrong food and it killing them.
Yeah.
But the head SOP, Allison, was like, "You're not going to kill anybody, like, it's okay." And so far I haven't, so we're winning. And dysphagia is specifically the leading cause of death in patients with Parkinson's.
What about patients with dementia?
Very common in patients with dementia as well.
Okay.
And that's a whole different ballgame. We'll talk
That's
a
what
little
I'm
bit
doing
about how to
now.
help them.
Yeah, that's what I'm working on right now, studying more on is dementia patients. I did
Right.
it before, but I'm back in school doing it now.
Relearning.
Yes.
Cool.
I love working with dementia. I just love it.
I'm glad
it's
that
a
you do.
learning experience and it's patience, but it's very knowledgeable.
Right.
And they're
That's good
normal
work.
like everybody should treat.
Mhm.
Yeah.
Some people be scared
people
with
don't.
dementia patients.
I love that.
Oh yeah, girl, I love it. I'm so ready. I mean, I'm loving all the different modules and stuff that I'm studying. I'm ready. I'm ready.
Good. All right, we'll get into a little more about aspiration pneumonia. There are 3 pillars of pneumonia, 3 primary causes. Obviously, to get aspiration pneumonia, you have to aspirate. Aspiration pneumonia is pneumonia of the lungs caused by aspiration. So you can get pneumonia without aspirating, but aspiration pneumonia is the dysphagia kind. For aspiration pneumonia to develop, a patient has to have a weakened immune system. It's a disease of opportunity. So if your body's not fighting stuff off, pneumonia's like, hey,
Yeah.
let me get up in these lungs. Another huge aspect of it is poor oral care. The mouth, if we've got some pocketing going on, we've got food particles that are a hazard to choke on or to go all the way down into the lungs. So we want to make sure we're clearing that pocketing well and helping the patients kind of take ownership of that themselves.
Yeah.
Kind of trying to train them on should we use a finger sweep and clear out some of that pocketing? Because we don't want to sit around all day with a whole bunch of food in our mouth.
Exactly.
Because so the importance of oral hygiene cannot be overstated as far as dysphagia goes. There's a lot going on with that, and we'll talk a little more about oral care here in a little bit. And the third pillar is the presence of aspiration. So you can't have aspiration pneumonia unless you aspirate. But with this, a patient can aspirate every time they drink a thin liquid. But if they have good health and they have good oral care, they may never get aspiration pneumonia. Meanwhile, a person who's sick and weak and doesn't really brush their teeth because they don't feel like it, or for any reason, they can aspirate one time and get aspiration pneumonia. So it's a little interesting there.
Yeah.
And aspiration pneumonia is deadly. It can be very deadly. Ways that you guys can help is to help raise patient awareness. We talk to patients about why we're putting them on certain diets and why they have to do the thickened liquids. But what I really want for, honestly, all of healthcare is to be a united front. Like, because they'll say to me, oh, I completely understand. I want to be safe, whatever. And then they'll come talk to you guys and be like, this speech lady's so mean. She makes me drink all these thickened liquids and I hate it. And can't you just give me some water? But if we're on the same page about what's going on and why they're on that diet, that'll be very helpful. And especially for our patients with dementia or just general memory problems, just reminding them like, hey, this is why we're doing this. Even if we have to tell them every 5 minutes. So when we make our diet recommendations to change a diet, most often it's based on the result of imaging studies, like our modified barium swallow or fiber optic endoscopic evaluation of swallowing, which is the FEES. With that one, we stick a tube up their nose, down their throat, and watch the food go down, see if it goes down the trachea or if it's going down the esophagus.
Oh, I can't do that.
It's a little bit gross, I'm not gonna lie. And then with the MBS, that is an x-ray of the swallow. So we get like a side view and we can see the oral stage, the pharyngeal stage, all the way down. That's why it's my favorite. We also make diet changes based on how well a patient is tolerating the diet. If they're perfectly safe to have like a soft and bite-sized diet, but it's taking them a long time to chew it up and they're not finishing their meals because they're tired, I may bump them down to minced and moist. So it's our clinical judgment of what's going to be the safest and most beneficial diet for the patient. And then finally is patient preference. I'm sure you guys have had some patients before who don't have any teeth and are like, can I get some softer food?
Oh, yeah.
We get that pretty frequently. And then right now I have a patient who's fine for soft and bite-sized, but it takes so long to chew that she'd prefer to be on minced and moist. So we're gonna let them choose within the realms of safety.
Gotcha.
All right, some safe swallow precautions, things you might can use to help out our patients with dysphagia. The number one most important thing we can do to protect us from aspiration pneumonia is oral infection control, or oral care, but I feel like it's such a big deal. Oral infection control probably gets the gravity of it a little more. So we're gonna want to clear pocketing. If they've eaten anything and there's pieces of food stuck in their mouth, anybody, whoever's near, please help them clear that out. We don't want to be sitting around with food in our mouth all day. It's bad for the teeth, it's a choking hazard, all the things. And also, brushing our teeth is so very important. We brush our teeth every day, but a lot of these patients, it can be hard. You know, we're running all the time. Nobody's helped me brush my teeth today. Okay, well, let's stop what we're doing and we'll do some oral care. Let's brush those teeth. And we got some different things in the nurse supply closet for oral care. We've got these lemon glycerin swabs. It says on the back, use to refresh dry mouth and throat, providing a pleasant and refreshing citrus flavor. And I know a lot of people have done these just to wet somebody's mouth with our NPO patients. They're like, please just give me something, this dry mouth is horrible.
Yeah.
But these actually dry out the mouth even more.
Oh, wow.
So it's a little misleading.
Is that because it's the lemon? Yeah.
That citrus dries it out. I think it's the lemon and the glycerin.
Yeah.
So even if it's a different flavor and it's glycerin, it's gonna dry out the mouth. These swabs are much better. I will wet them and rub them around for a patient who's NPO and has a dry mouth. That's very beneficial. Dry mouth is horrible. So it feels bad, it tastes bad, and it will change the chemical structure of the mouth. So the mouth will stop putting out as much saliva, and it just will lead us down a whole bad road. Like that's, we could talk for hours on that. It's bad. So these are great for that. These are also really good for clearing pocketing if you don't want to shove your finger in somebody's mouth.
Yeah.
Sometimes I've been afraid that I'm going to get bit. So these are really good, and you can also kind of teach people, because you just shove it in the back, scoop it up to the front, and you can either spit it out or people scoop it up with their tongue and swallow it. Lots of different things. For clearing pocketing, I usually like to have them do a lingual sweep first, see if we can get it out with our tongue. A lot of them have limited motion in the limited range of motion in the tongue. So that helps improve the range of motion and gives them a chance to do it discreetly, which is much less embarrassing. Then I'll usually tell them to do a finger sweep after that. But the swabs are a great alternative to the finger sweep. So with brushing our teeth, we want to use a toothbrush and toothpaste like we would ourselves. Even if they don't have teeth, we're going to want to scrub everything in their mouth. So everything from the teeth, the roof of the mouth, the cheeks, and specifically the tongue. The tongue is like a sponge for bacteria. I'm sure y'all have heard how much bacteria the mouth has. It's similar to a public toilet. Like, there's a lot going on here. So oral infection control is of the utmost importance. We also have the Fraser Free Water Protocol. What is that?
I have no idea.
Okay.
Full of water and ice chips between meals.
Yep. Water and ice chips between meals. We'll have signs outside that say "Okay for ice chips."
That's what I was
Yeah.
thinking about.
Exactly right. Y'all have seen
I
those,
see them.
and y'all follow them.
Yep.
I know
Yep.
that's happening.
Yeah.
But this is what it's called: Fraser Free Water Protocol. So with this, it encourages patients to drink water and increase their hydration. It's specifically for people on thickened liquids, and they're just so excited to have some thin liquids that they're like, yes, give me all the water. So, as much water as they're willing to drink, keep it going. And water, it's only with water because water is natural to the body. If you swallow a Coke into your lungs, the body's going to be attacking it. It's like, what is this? We could get some aspiration pneumonia. But water is natural, so the body doesn't attack it. And then some people can have water, some people can have ice chips, some people can have both. But the SLP should make that clear on the board outside their door. The biggest thing with the Fraser Free Water Protocol is that it's after oral care. We don't want that bacteria from the tongue to come down and risk pneumonia. So even if they are choking, if they've done their oral care, they're going to be safe with the water. And we want to wait at least 30 minutes after meals before we give them the water. Why do you think that might be?
Then we're gonna wait.
We're going to wait 30 minutes after they eat.
Could it wash the food to another place?
Yep, so we don't want any food particles going down with it. And the oral care will help take care of that too, but surely after 30 minutes we can clear out some pocketing. And then another reason is reflux, specifically for patients with GERD. That esophageal reflux, it'll come all the way up, and it's as much an aspiration risk as eating. So we don't want them to swallow some reflux down with their water. You can make postural changes. For some patients, if they've had a stroke and they're weak on one side, we can turn to the weak side, and it helps close up the airway when those muscles aren't working. Another one is the head tilt. If they've got oral dysphagia and they keep pocketing, you can turn your head to the strong side or tilt your head to the strong side so that the strong cheek isn't letting food get down in the pocket where the weak side will. So it significantly eliminates the amount of pocketing. The chin up posture is especially helpful, like taking pills needles and stuff.
Mm-hmm.
And it's just, and that's for our patients that have a hard time getting it to go down in the first place. So with that, we're kind of letting gravity do the work.
Gotcha.
The chin tuck, I'm sure you've heard of the chin tuck.
Mm-hmm.
Putting your head down while you swallow. It only works if you do it. It only works when you do it.
Mm-hmm.
And with that, for some, it's really great. It closes up the airway, prevents aspiration. But for others, the second they pull their chin back up, there's residue from their throat that goes straight into their airway.
Mm-hmm.
So the chin tuck is not appropriate for everyone, and the only way to make sure that it is appropriate is with those imaging studies again. We've also got environmental changes, like having access to appropriate snacks that fit their diet and that they actually like. With a lot of our patients, they don't really want to eat because it's a weird diet, and they're, for any different reason, they may not want to eat. So it's important to take advantage of the times that they feel like eating. We really want to have those available for them. You can, reducing distractions is also super important, especially for our patients with dementia. They get distracted and forget that we're eating, or look over here and start coughing.
Yeah.
So that's especially helpful for those with dementia. Some compensatory strategies we use: small bites and sips, very important. We don't want to overload anything, because the more food we have in our mouth, the more likely we are to choke on it. Some of them aren't cognitively there enough to know that they're eating too fast.
Mm-hmm.
So it's important a lot of times to remind them. Pacing is another thing of overloading. Some patients want to eat like somebody's going to take their food away in 5 minutes, and then some patients, like our dementia patients, may eat way too slowly, and they get worn out because they've been sitting here for an hour. So sometimes it's good to be like, okay, it's time for another bite.
Right.
Alternating liquids and solids is really helpful, especially if we've got some food getting stuck in our throat or getting stuck in our mouth. We can be like, hey, have a sip of water. I recommend about every 3 or 4 bites or so, drink some water, and that'll just help wash everything down. The effortful swallow, the way is good for pushing down things that are stuck. The way I describe it to the patients is it's like you have a golf ball that you're trying to swallow. So you would have to swallow really hard. I want you to try that with me.
Okay.
Yep, that was a lot of effort you put in. That was a lot of effort. So that's good if something's ever stuck. It's never going to hurt anything.
Okay.
So you can always use that. And another one that will never hurt anything is the double swallow. Swallow again. If you're hearing that gurgly voice, tell them to swallow again. If it looks like they've got stuff still in their mouth, swallow again. It just clears all the residue.
Gotcha.
And again, coughing is good. That's the protection of the airway. We're excited when they cough. Encourage it. I have to tell a lot of patients, like, here, let's take a break, have some water.
Yeah.
That's always helpful. And a lot of patients with our pocketing need to be cued. Either they don't feel it, or they feel it and they just don't think, let me get that out.
Mm-hmm.
So a lot of them need to be reminded to clear that residue. All right. There are my references. Do you have any questions for me?
Not really, but that was very informative.
Okay. Well, thank you.